Thank you, Ranking Member. I now call up H.R. 740, the Access Act of 2025. The clerk shall report the bill.
H.R. 740, to improve the provision of care.
The text was circulated in advance and pursuant to committee rules without objection. The first reading is dispensed with. The bill is now open for amendment at any point. I now recognize myself for the purposes of offering amendment in the nature of a substitute. The clerk shall report the amendment in the nature of a substitute.
Amendment in the nature
I
of a
ask unanimous consent that any further reading of the amendment in the nature of a substitute be dispensed with. I ask that it be considered the base text for the purpose of this markup, and without objection, so ordered. I now recognize myself for 5 minutes to speak in support of the amendment and the nature of a substitute. The Veterans Access Act strengthens and promotes the Veterans Community Care Program. It picks up where the Mission Act and Choice Act started. Many of us members remember the wait list scandal of 2014. It is clear now as then veterans deserve health care choice. Community care is VA care. This bill would not privatize VA. I'll say that again. This bill would not privatize VA. 14 veterans groups and the veterans they represent stand behind this bill. Time and time again, veterans tell us about the roadblocks to their legal right to community care. Their stories demand action. The Access Act delivers. This bill, for example, would prevent bureaucracy from fudging wait times. A lawsuit revealing that employees who scheduled appointments at VA misrepresented dates of patients' request. That sleight of hand made wait times look shorter on paper, but it was a cook-the-books operation that harmed veterans, and our bill would do even more to empower veterans' choice. Let me make one thing clear. Veterans don't need their hands held. It's their health care. Our bill would make sure that the eligible veterans know their telehealth options. Telehealth is a lifeline that saves precious time driving, especially for rural veterans. For visits safe to be done online. Constituents in rural districts, like mine, and in other districts for many members on this committee, benefit from more telehealth operations. This bill would also create an online self-service healthcare dashboard. Why shouldn't veterans have this common sense tool at VA? Unfortunately, veterans tell us VA treats their care like a favor, not care they have earned. These changes would promote a culture at VA to treat veterans with the dignity they deserve. Our bill would also hold the Center for Innovation for Care and Payment accountable. I cannot tell you how many times members of this committee have asked, why does this center, what does this center do? The answer, crickets. This center has not innovated care. It has not innovated payment. It is time that changes. And our bill would make sure veterans know about community care fast. Veterans repeatedly tell us, I heard about community care months after trying to get an appointment, or worse, I never knew. The stories go on. Veterans are either delayed care or left without care. And it is a failure and a stain on the Biden administration for discouraging community care. The Biden administration conduct was not a one-off omission. It was a system-wide failure. With my ANS, this bill would take key steps toward better care for veterans. But this is not the end of the road. We want to require VA's referral standards prioritizing veterans' preference for care. Too many veterans have been denied their choice of provider in community care. We also wanted to increase access to residential rehabilitation treatment programs. These treatment facilities are available in the community and able to serve veterans, usually within 48 hours of referral. Unfortunately, the referrals process is often delayed. Before we can act on these policies, we must ensure they are fully paid for. But rest assured, I am committed to work with VA and our colleagues to restore these provisions. I urge my colleagues to support this bill and continue with this committee's work on behalf of the veterans we serve. Do any other members wish to comment on the amendment in the nature of a substitute to H.R. 740?
Mr. Chairman.
Ranking Member.
Mr. Chairman, I have an amendment to the, oh, my comments, I'm sorry. Yeah, Mr. Chairman, I strongly opposed the ANS to the so-called Veterans Access Act, which directly threatens the future viability of the VA healthcare system as we know it. It risks reducing veterans' choice and access to VA care. It risks reducing veterans' choice and access to VA care, despite what its proponents may claim. While I do appreciate that the majority has removed several harmful sections of this bill they originally introduced, which I think reveals a privatization motivation, and while I do appreciate the majority has removed those harmful sections of the bill, they did so because they have changed, not because they've changed their minds on the policy, not because they've changed their minds on privatization, but because the committee lacks sufficient offsets to pay for them. And that reveals another point, that privatization, lopsided privatization, because this side is not, we're not opposed to care in the community. There's a proper role for care in the community, but in the proper proportion. Privatization also is costly, and it is expensive, more expensive than direct care when it's not in that proper proportion. Nevertheless, as will be made clear through the amendments to the ANS that my colleagues and I will offer today, this legislation remains riddled with provisions that will do little more than hasten the outsourcing of veterans' health care, divert resources away from VA's direct care system, and dismantle VA's model of integrated, coordinated health care. Of greatest concern is the pilot program that would be established under Section 202, subsection C. It would create a 3-year pilot program in a minimum of 5 VISNs, whereby veterans would be able to seek outpatient mental health care and residential substance use disorder treatment from community providers without any authorization or referral and without any limit on the number of appointments or admissions. This is deeply troubling to me, as it should be to everyone who is invested in decreasing death by suicide among veterans. The majority of veteran suicide deaths occur among the veteran population that is not connected to VA. It would follow that connection to VA is a key aspect of prevention. Leaving veterans untethered in the community with no way for VA providers to know how a veteran is doing and whether they are continuing care and treatment is harmful. It's harmful to the veteran. Requiring referrals keeps that connection, that relationship in place, and it can be life-saving. This provision will also lead to a dramatic increase in spending on private sector care, diminishing the availability of resources for investments in VA's direct care system. And I have little doubt this will end with a I have little doubt that this will end with a 3-year pilot. Our Republican colleagues will do everything they can to make sure that this program becomes permanent. I am also concerned about a provision that was not in the underlying bill but slipped into the ANS. The chairman has added within paragraph 2 of subsection A language that would enable veterans to no-show or skip their scheduled VA appointments in order to become eligible for community care appointments. Now, what this will do will deprive veterans of accessing those VA appointments, waste resources within VA's direct care system, and lead to even more spending on community care. For these and other reasons that will become clear as we discuss our amendments, my colleagues and I cannot support the chairman's ANS. So thank you, and I yield back.
I find it funny that now that the Republicans are in control, some of our colleagues are suddenly wringing their hands over so-called threats to VA. Let me be clear. The Veterans Access Act is about one thing: putting veterans first. It's about giving them real choice, real access, and real accountability when it comes to their health care. And it's not just Republicans saying that. This bill is supported by a broad coalition of veterans, service organizations, groups like the American Legion, the VFW, AMVETS, Concerned Veterans for Americans, and many others. These organizations represent millions of veterans who have made it clear community care is not a threat to the VA. It is not privatization. It is necessary. It is a necessary add to what we provide at the VA. And I'm tired of hearing the argument that opposing this bill somehow protects veterans. It doesn't. It protects bureaucracy. It protects the status quo. What it does do is protect the veteran waiting months for life-saving appointments or driving hours for basic health care. For my position as chairman, we're fighting for those veterans who kept their promise to this country and deserve a system that keeps its promise to them. I welcome my colleagues on the other side of the aisle to join us in this bill. Is there any other one seeking a comment on this legislation? Ms. Browning.
Yes, excuse me, Mr. Chairman, I have an amendment at the desk.
We're going to start amendments here shortly.
Oh, sorry.
Are there any amendments to the amendment in the nature of a substitute on H.R. 740?
Sorry.
I have an amendment at the desk. I have an amendment to the amendment in nature of substitute to H.R. 740 at the desk.
I now recognize, amendment to the amendment in the nature of substitute of H.R. 740. I now recognize ranking member to offer an amendment to the amendment in the nature of substitute. The clerk will report the amendment.
It's Condo Amendment 3.
I ask unanimous consent that further reading of the amendment is dispensed with, and without objection, so ordered. The gentleman is recognized for 5 minutes to explain his amendment.
Well, thank you, Mr. Chairman. My amendment strikes language in Section 101 of the NS that bars VA from taking into account the availability of VA telehealth appointments when determining veterans' eligibility to receive community care. Now, this short-sighted provision will result in more veterans receiving more expensive care in the community, all the while taking away the ability for veterans to make a truly informed choice of where and how to receive their care. If this is about choice, veterans need a true choice, and this short-sighted provision will result in more veterans receiving more expensive care in the community, all the while taking away the ability for veterans to make a real choice. In fact, surveys of veterans have found that 80% of veterans find VHA telehealth care to be as helpful or even more helpful than in-person appointments when receiving mental health care. The reasons for this are obvious and applicable in many Americans' lives, not just veterans. Sometimes the hassle of receiving in-person care simply doesn't make sense when you can receive care from the comfort of your own home or office. And yet, when VA is determining whether veterans are eligible for community care referrals, it only takes into account the wait time for in-person appointments, even if the veteran would prefer to receive care via telehealth. As a result, veterans end up bypassing available VA telehealth appointments and end up receiving services from community care providers via telehealth. This is inefficient, and it's a wasteful use of VA's resources. I will acknowledge that VA's current technology does not allow the department to systematically take into account the availability of VA telehealth appointments when determining wait time eligibility for community care. However, VA has long been working to modernize its appointment scheduling technology in a way that would enable the department to factor in real-time nationwide availability of VA telehealth appointments in the future. This ANS would effectively prohibit VA from ever adjusting its eligibility determination process to reflect that. So my colleagues across the aisle like to talk about giving veterans the choice of how to receive their care. And yet, this ANS, as it's drafted, would give veterans less choice in opting for telehealth. At a time when more veterans than ever, when more Americans than ever, are receiving and prefer to receive telehealth when it makes sense and when clinically appropriate, this is an unacceptable double standard for veterans. That is why my amendment would strike this prohibition from the ANS and allow VA to take telehealth appointment availability into account when determining community care eligibility. I hope all my colleagues will join me in supporting this amendment, and I yield back.
Gentleman yields back. I recognize myself in opposition to the amendment. I oppose the amendment because it puts VA's convenience ahead of the veteran's needs. VA already has the authority to offer telehealth, and in many cases, it can be beneficial. But it should always be the veteran's choice to decide if telehealth is right for them. To include telehealth in access and wait time calculations would pressure veterans into virtual visits they may not want, just to avoid eligibility for community care. For those who prefer or require in-person treatment, this would take that choice away and create confusion. This is not veterans-centered care, and I strongly oppose it. Does any other member wish to comment on the amendment? Seeing none. The question now occurs on agreeing to the Tucano number 3 amendment to the amendment in the nature of a substitute. All those in favor say aye. Aye. All opposed, no. No. In the opinion of the chair, the noes have it. Without objection, the motion reconsidered laid on the table. I now recognize Representative Brownlee to offer an amendment on number 4 to her amendment in the nature of a substitute.
Thank you, Mr. Chairman. As you know, I've always made it clear that there must be a balance between direct care and community care for our veterans.
The clerk, oh, you have an amendment at the desk.
I have an amendment, Mr. Chairman. I have an amendment at the desk. A little rusty this morning.
You're new.
Brownlee Amendment Number 4, amendment to the amendment in the nature of a substitute to H.R. 740, offered by Ms. Brownlee.
I'm asking that, and we don't have to do it because he already read it. So, without objection, to order. The gentle lady is recognized. There we go. Now I'm caught up.
All right.
Confused
Here I
us
go. Okay. Third time's a charm. Thank you, Chairman Bost. As you now know, I've always made it clear that there must be a balance between direct care and community care for our veterans. However, the ANS to the Veterans Access Act of 2025 does not contribute to a sustainable balance between community care and direct care. Instead, its implementation would lead to a drastic expansion in community care to the degree that community care would supplant rather than supplement direct VA care. One example of this is how the amendment in the nature of the substitute adds a provision that would enable veterans to no-show for VA appointments and still have their community care eligibility determined based on the date they originally requested an appointment, essentially making them automatically eligible for community care. This policy would deny other veterans access to VA appointments and waste valuable time and resources of our VA providers who are already dealing with staff shortages and long wait times across the country. It also has the potential to significantly increase the number of veterans using community care, which in turn would increase overall costs of community care, slowly eating away at VA's ability to provide direct care for our veterans. My amendment would strike this provision that allows veterans to no-show for VA appointments as a means of being offered community care referrals. I urge my colleagues to support this amendment and ensure that VA is able to utilize its direct care appointments to provide quality care for our veterans. And with that, Mr. Chairman, I yield back.
The gentlelady yields back. I recognize myself in opposition to the amendment. The amendment would remove no-shows from the definition of canceled appointments. I, along with many of my veteran colleagues, have personally experienced VA canceling appointments on our behalf, and we never even knew we were scheduled. And as we have heard from multiple witnesses' testimonies at this Congress, this problem is not an isolated one. Veterans throughout the country deserve a VA that provides excellent customer service. This amendment would undermine that effort. I oppose the amendment, and I urge all of my colleagues to do the same. Does any other member wish to comment on the amendment?
Yes, Mr. Chairman.
Ranking member.
So if this issue of canceled appointments without the veterans knowing about it is an issue, and it's been documented, the target should be that VA process. We should be overseeing VA and insisting that they discontinue this practice. But to throw out completely a tool to say that we incentivize veterans to not show up for their appointments so they can qualify for community care, you know, it's common sense. We're going to see that.
That's not what the amendment, or that's not what the
policy. Your present ANS allows for that to happen, and that's what we're trying to fix here. I completely oppose, and I would say all members here would oppose allowing the VA to cancel appointments, what you just said, without the veteran's knowledge, and that is a waste of resources. But it's likewise a waste of resources for a veteran to not show up for their appointment, deny other veterans that could have used that appointment, and then go into the community for care that is probably going to be more costly to the taxpayer. We're just trying to enable. It's our job to oversee VA and to make sure they're operating as a system efficiently and properly. Not to set up. It's not in our interest or the taxpayers or the veterans' interest to set up a system whereby we encourage waste. This is an encouragement of waste, and that's exactly what I thought this administration was opposed to.
And I simply disagree with you that it's a waste. The problem is that we're hearing about it being used as a tool against the veterans in a way that should not be done. And many of us as veterans have had this problem occur. So it would have been great had they done it on their own, but that's why we're carrying a law to make it force them. And we do that all the time here. That's what we do. When we see problems in the VA, we create a law to try to correct a problem. This corrects a problem where we have VA employees using this particular measure as a tool to deny our veterans certain services.
Mr. Chairman, might I yield some time for Ms. Brownlee to respond?
may.
Thank you.
Thank you, Ranking Member. And Mr. Chairman, I think you're referencing a different provision in the bill, one that deals with VA canceling the vet's appointments. Your amendment strikes the language right below that to enable the vet to no-show. And it is, I'm sorry, where is it? Right, exactly. So I'm talking about the language that says includes a scheduled appointment for which the veteran fails to appear. You're talking about the means a scheduled appointment with a healthcare provider of the department that is canceled by the department for a reason other than requested by the veteran.
Right. All that does is provide them their choice. So it doesn't allow them to be punished for a misscheduled appointment. And
I know, but the language is really referring to what my amendment is about the part of the bill that talks about no-shows, that if a veteran doesn't show up for an appointment, a scheduled appointment, then he or she then has complete access at that point to go directly to the community care.
I feel our language is correct. Okay.
I don't.
I got it. I
And I
it.
hope my side will vote in favor of my amendment.
You recognize
Okay, thank you, Mr. Chair. I just want to acknowledge, as a physician who has a hard time getting my patients in prior to this, especially at the VA, where it takes time for people to get an appointment, if we do not use those appointments wisely, it cascades to less accessibility for all veterans. So if someone knowingly uses an appointment that is scheduled, not intending to come in as a means to get a community care referral, that is a failure of our system. Community care referrals should be easy to come by, and I certainly don't want to get in the way of that, but using appointments to be able to access that is a waste in the system and will delay care for all veterans. It absolutely should not be used as a means to being offered community care. I agree with the sentiment that veterans should have the ability to miss appointments, but if it is for the mechanism of getting a community care referral, that should not be in this bill. And I strongly support this amendment.
Yield back. Any other? Seeing none, The question now occurs on agreeing to the Brownlee amendment, in the nature of a substitute. All those in favor say aye.
Aye.
Opposed, no. No. In the appearance of the chair, the noes have it. The agreement is not agreed to. Without objection, the motion to reconsider is placed
Mr.
on.
Chairman, I request a recorded vote.
A recorded vote has been requested pursuant to committee rules. This vote will be postponed. I now recognize Representative Conaway to offer Conaway Amendment Number 5 to this amendment in the nature of a substitute.
I thank you, Mr. Chairman.
You have an amendment at the desk? Clerk will report the amendment.
Conaway Amendment Number 5.
I ask unanimous consent for further reading of the amendment to be dispensed with, and without objection, so ordered, the gentleman is now recognized for 5 minutes to explain his amendment.
I thank you, Chairman Bost. My amendment revises a provision of Section 104 of the ANS pertaining to the discussion of telehealth appointments as an option for care. I appreciate that the Chairman's ANS will require the VA to discuss telehealth as an option for care. He has stressed that veterans should have an option in how they receive their care, both within the VA healthcare system and in the community, when telehealth is available and appropriate and acceptable, and this is the key phrase there, acceptable to the veteran. While there aren't many bright spots in the COVID-19 pandemic, one positive outcome is that it accelerated the delivery of care via telehealth. Seemingly overnight, healthcare providers nationwide, including the VA, figured out how to efficiently deliver a wide variety of services via telehealth. And many patients, including veterans, found they liked it. It saved them from taking lots of time off work, finding someone to transport them to VA or other clinics, making long drives, circling the parking lot, finding a spot, et cetera. It was a great convenience. In New Jersey, where I passed telehealth legislation and the subsequent study found that it saved money. It offered a great deal of, it was widely received by the public and delivered care that was essentially the same as they might receive in an in-person setting. My amendment is simple. If a telehealth appointment is clinically appropriate and the veteran wants to have their appointment via telehealth, agrees to that a telehealth appointment and wants to be seen via telehealth, then the eligibility for community care referral should be determined on the basis of wait time for VA telehealth appointment. That is, determine what the wait time is within the VA for that veteran who desires to get their health care via telehealth and not via an in-person appointment at the VA as it is now. If the veteran has expressed interest in a telehealth appointment, they should not be bypassing available VA telehealth appointments only to eventually receive telehealth in the community. My amendment would ensure that existing VA resources are used efficiently and that the VA's clinical capacity is fully maximized. I urge my colleagues to join me in supporting this amendment, and I yield back.
Gentleman yields back, and I recognize myself in opposition to the amendment. As I stated earlier, VA already can offer telehealth appointments to the veteran, but it should always be veterans' choice to decide if that is right for them. I oppose the amendment, and I urge all of my colleagues to do the same. Does any other member wish to comment on the amendment? Seeing none? Well, no, okay. Seeing none. The question now occurs on agreeing to the Conaway Amendment, number 5, to the amendment in the nature of a substitute.
Mr. Chairman, if I wish to be recognized,
Okay.
and I will yield to Mr. Conaway.
Okay, there we go.
Just briefly, the point of my amendment is to make sure the veteran can exercise the option to use telehealth if the veteran thinks that that is in his or her best interest. I yield back.
And as I said, they already have the option right now, but in no way should they be forced to take that option. It should be the veteran's choice. He yielded back.
I yield back, Mr. Chairman.
Okay. The question now occurs on agreeing to the Conaway Amendment number 5, the amendment in the nature of substitute. All those in favor say aye.
Aye.
All those opposed, no. No. Opinion chair, the noes have it. Yes, you sure can. A recorded vote has been requested pursuant to committee rules. This vote will be postponed. I now recognize Representative Dexter to offer an amendment in the nature of a substitute.
Mr. Chairman, I have an amendment to the amendment in nature of the substitute at the desk.
The clerk shall report.
Dexter Amendment
I
Number
ask
6.
unanimous consent that further reading of the amendment be dispensed with, and without objection so ordered. The gentlelady is recognized for 5 minutes for her amendment.
Thank you, Mr. Chair, and thank you to my colleagues for your attention to this important amendment. This amendment represents a necessary step toward greater accountability, transparency, and patient empowerment at the VA Community Care Program. At its core, it's about putting veterans first. It's about ensuring that those who have worn the uniform, who have sacrificed for this country, are given the information they need to make informed, patient-centered decisions about when and where to receive care. Under current law, veterans are eligible for referrals to community care if the VA cannot provide an appointment within 20 or 28 days, depending on the type of care. These standards were put in place under the Mission Act with the intention of expanding timely access. But there's a major flaw. Veterans are being asked to choose between staying within the VA system or seeking care in the community without knowing whether that outside provider can actually see them any sooner than the VA. We are telling them that they have a choice, but it's a choice made in the dark. No comparative data on wait times, no visibility on drive times. This is not patient-centered care, and that is not transparency. So, my amendment directly addresses this issue. It would require the VA to provide veterans with data comparing wait times and drive times between VA facilities and community providers so that veterans can make meaningful decisions about where to get their care. If we're serious about access, if we're serious about quality, then we must be serious about giving patients real information. Community care is meant to be an extension of the VA, not a substitute for it. But when veterans are directed to the private sector without full information or meaningful coordination, the system breaks down. It creates confusion, disrupts continuity of care, and too often leaves patients navigating a fragmented system. Too often, veterans are left trying to stitch together the system on their own. They don't know who's responsible for what. They don't know when or if they'll be seen. They don't know if their treatment will be coordinated across the systems. This results in delay, confusion, and far worse, preventable breakdowns in care. This is not just frustrating, it's dangerous. For the sake of our veterans, we must build a system that functions, not just on paper, but in practice. That means ensuring every VA patient receives timely, high quality, and coordinated care, whether that care is delivered inside the VA or by a community provider. And the only way we can do that is by arming veterans with the information they need. My amendment gives them the tools to make those comparisons on wait times, on travel times, on outcomes, because true choice requires good data. So let me close with this. This should not and must not be framed as a fight between VA and community care. That's a false choice. That's the wrong debate. The right question is, what does the veteran need, and how do we deliver that care responsibly, quickly, and with the highest possible quality? This amendment empowers veterans with the data they need to make informed choices. It promotes transparency and accountability and takes a meaningful step toward building a system that delivers on our promises. Because here's what really comes down to. When we send men and women to fight for this country, we make a commitment to stand by them when they come home. This promise doesn't end when the uniform comes off. It doesn't end when the war is over. And it's a lifelong commitment. So if we truly believe that, if we truly want to honor that, then we have to give this right to them. This amendment is one small but powerful way to do it. I urge my colleagues on both sides to support it. Thank you, Mr. Chair. I yield back.
Lady yields back. I recognize myself in opposition to the amendment. I oppose this amendment because it gives scheduling control back to the VA bureaucracy that has repeatedly failed. During the last administration, VA was found to have manipulated wait time data and appointment availability. The Veterans Access fixes that and would create a useful tool to allow veterans to make informed decisions and schedule their care without relying on VA administrators who may or may not be providing accurate information. The amendment would undercut those efforts, and that's why I oppose it. Does any other member wish to comment? Ranking member.
Mr. Chairman, this does not give power to the bureaucracy. It gives power, Dr. Dexter's amendment gives power to the veteran by giving the veteran more information. Dr. Dexter, would you like to respond?
Yeah,
I yield to you.
Thank you so much, Ranking Member Takano, for that. That is precisely it. It doesn't do anything to the VA. What it requires is that the data from community care is available so that data can be compared, not manipulated, not weaponized, but so that the community care providers have to provide the same data that the VA must provide so that they can make an informed decision about where to get care. If they want community care, and they're willing to wait longer, that is a decision the veteran should have. But if they want care sooner than later, and the VA can provide that sooner than community, they should be able to have that information. That's simply not available right now.
And common sense would say that that VA already had that right and they blew it. During the last administration, there's a real problem here with the VA and their concern over not using community care. And they've given false information to our veterans and not giving them the full information as what available to them. That is why we're putting this in, and that's why we're having, this is the problem. When you have a bureaucrat that wants to stand in the way of what we pass in law, and just so you know, we've got emails from the upper, that was sent out to our VISNs saying to make sure community care is not an easy button. That is the problem. We have that information, and that's what we're dealing with here. So we're saying to go ahead and turn it back over to them, thinking that they will give that information correctly. They could have given that information correctly before, but they chose not to.
Mr. Chairman.
Yep.
Reclaiming my time. Dr. Dexter?
No, thank you so much. So just to be clear, I just want the community to have to provide that same information, and that has not been required. So it is simply asking for that, and I am not saying anything about what the VA is suggesting or doing with their data. We should require good quality, reliable data from the VA as much as we do from the community. There is no question here in my mind. What we need is to center the veteran and make sure that they have good quality data that is updated and appropriately reflects the actual wait time as well as drive time. I think we both want the same thing, and all this does is asks for the community to be accountable for supplying that data as well as the VA. Thank you.
Yeah, thank you for reclaiming my time. Mr. Chairman, I think this committee should hold more hearings into community care coordination. We should have more. I want to know about instances that you are saying happened under the previous administration. I was here during the wait time scandal during Phoenix, and that was a terrible thing. It is this committee's job to hold the bureaucrats responsible if they are bad actors and if they're not treating the veterans right. But it is not in the veterans' interest or in the American taxpayers' interest to create an imbalance between the direct care system and the community care system, dismantle and disable the coordinated nature of it. That doesn't help the veteran if we can't get the records back and coordinate the care with community care providers. I think a veteran should be able, if they're eligible, that 30-day mark happens and that drive time, that if they're given the option of community care providers, they should know how long it's going to take to drive to that community care provider in the community versus go to the VA even after they're eligible and say, yeah, even though I'm going to wait a little longer, I'm going to stick with the VA because it's going to take me longer to get there. They should have that information. That's all Dr. Dexter is saying. I would go further. I think every American, when they enroll in a health care plan and they're choosing between 10 health care plans, they should know which health care plan has wait times that are this long for oncology versus this health care plan. That information is not available. We've only seen this insistence that VA be accountable for wait times, but no one else in the community. And so it's not a real choice for a veteran to say to be moved into the community. That's more choice. The real choice is, hey, I may have to wait a little longer for the VA appointment. because I have to drive longer to get over here. It's more inconvenient. So they're going to, that's real veteran choice. And all Dr. Doctor is saying is, let's make that information also required of the community care system. They should know how long it's going to take to get there, how long it's going to take to get that appointment, and have them weigh what's available in the VA. And we are getting the technology available to make that happen. And I yield. I'll yield back.
Okay, I'm still going to oppose it at this time, but I will, as we move forward, because this bill needs to move forward, and we will look to see, because I believe our language allows that choice for the veteran and tries to stop the problems that were occurring. I will look at it a lot closer, but we're going to move forward with this, and I'm still going to oppose the amendment.
And what about hearings into the community care coordination?
We can see while we're doing that later on, but right now with this markup, and we'll look into that. Take it under advisement. Anyone else?
Mr. Chairman, I think our language is very clear to implement such other matters as determined appropriate by the Secretary in consultation with third-party administrators. That's the language that is good enough here. If I could just suggest to my colleague, perhaps just a letter from the Secretary expressing an interest in exact implementation of that paragraph, rather than us trying to put something into law that the Secretary can do today. All we need to do is indicate an interest. Mr. Chairman, I'll oppose this, but I think there is a way forward for my colleague. Thank you.
Thank you. Anyone else? Seeing none, the question occurs on their agreeing to the Dexter amendment, to the amendment in the nature of a substitute. All those in favor say aye.
Aye.
Opposed, no. No. In the opinion of the chair, the noes have it, and the amendment is not agreed to.
Mr. Chair, may I request a roll call vote? Thank you.
A recorded vote has been requested pursuant to the rules. This vote will be postponed. I now recognize Representative Brownlee for amendment number 7 to the amendment of the nature of substitute.
Chairman, I have an amendment at the desk.
The clerk will report.
Brownlee Amendment
I
Number
ask
7.
unanimous consent that further reading of the amendment is dispensed with, and without objection so ordered, the gentlelady is recognized for 5 minutes.
Thank you, Mr. Chairman. In this Congress, between the Health Subcommittee and Full Committee, we've already had 4 hearings conducting oversight of community care at VA. During these hearings, my colleagues and I have advocated for many ways to improve the community care program, including policies to require more transparency from community providers and expand VA's ability to oversee providers to ensure they have the same quality of care that we expect from our VA providers. On this issue, Mr. Chairman, I'm happy to work with you to improve upon the process in terms of obtaining outpatient mental health care. But this provision within the VA's Access Act creates a 3-year pilot program to allow veterans in at least 5 VISNs to obtain outpatient mental health and residential substance use disorder treatment from community providers without VA referral or authorization. Does what I believe is not good ultimately for the veteran. It poses an irreversible threat to VHA's survival as an integrated healthcare system by shifting VA's primary role from being a coordinator of care to merely paying invoices for veterans being treated at outpatient and residential facilities. Eliminating VHA as the authorizer of care means that over time, there will be fewer, not more, options for veterans, since more funding and resources will have to go to the community as this pilot will provide completely unfettered access to community providers. I'm especially concerned about what this will mean for residential rehab. There is a serious lack of oversight over community providers of residential substance use disorder treatment facilities. We are already seeing providers targeting veterans for admission to their facilities because of their potential to profit from VA's lack of a fee schedule. I understand the desire to ensure veterans have access to mental health care. That's something we all want, but there is no guarantee that veterans receiving care in the community will get better, more timely access to care, and we don't know if they do because VA doesn't track that. When veterans do access care at residential treatment facilities in the community, we have no way of knowing the level of treatment or support they're getting. We don't know if veterans are receiving care from providers who understand what it means to be a veteran and can establish a rapport with their patients. We don't know if they are being referred back to VA care in a timely manner, as VA is in the best position to coordinate their overall care beyond treatment for their substance use disorder, which is often just one aspect of their overall healthcare needs. This pilot program is clearly a giveaway to private sector entities that have a vested financial interest in treating veterans, a population that they admit in their own hearing witness statements that they have not been able to access because so many already receive care at the VA. This is why my amendment to strike this provision from the amendment in the nature of the substitute is needed. I'm offering this amendment because I have real concerns, and they are worth discussing today, Mr. Chairman. And as I said earlier, I'm happy to work with you in any way to streamline this process, but we should not lose coordination and oversight of the veteran and the VA's patients. And we certainly must have a pricing schedule for what that all is. But I know, Mr. Chairman, you disagree with that, so at this time I will respectfully withdraw my amendment, and with that I will yield.
The lady withdraws her amendment. I now,
That you'll work with me.
I will. Okay. I now recognize Representative Sheffield McCormick to offer the amendment in the nature of a substitute.
Thank you, Mr. Chairman. My amendment to
You
HR.
have a member at the you have an
Oh, I have
amendment.
an amendment at desk.
The clerk will report the amendment.
Sheriff McCormick, Amendment Number 10.
I ask unanimous consent that further reading of the amendment be dispensed with. Without objection, so ordered. The gentlelady is recognized for 5 minutes for her to explain her amendment.
Thank you, Mr. Chairman. My amendment to HR 740 institutes common sense community providing training requirements to ensure veterans are receiving the highest quality and culturally competent mental health and substance use disorder care they deserve. To become a mental health provider at the VA, individuals are mandated to undergo extensive training related to military culture, traumatic brain injury, PTSD, and opioid safety. These stringent requirements exist to address the unique healthcare needs to our veterans that are not typically found in the civilian population that necessitate specialized treatment. Whether a veteran receives care directly from the VA or from the community, the standards for mental health providers should not differ. Unfortunately, Section 202 of the Access Act, as currently written, creates a pilot that allows unfettered veteran access to outpatient mental health and substance use disorder services with virtually no safeguards and no guardrails on competency or qualifications of community providers treating veterans through this program. Under this bill, mental health providers, regardless of their background and familiarity with the military culture and conditions that disproportionately affect veterans, would be able to participate in this program. The pilot fails to ensure that community providers treating veterans have on issues like PTSD, traumatic brain injury, military sexual trauma, which they have little or no experience treating. My amendment resolves this by mandating that non-departmental providers complete training through the VHA Train platform within 180 days of enactment of HR 740. Community mental health care providers would be required to complete the very same training that is required for VA mental health providers. If a provider fails to meet this initial deadline, my amendment will authorize the VA Secretary to issue formal warnings and grant an additional 60 days for the provider to comply. If the provider were again to fail to complete the requisite training, the VA Secretary would place the provider on a temporary 90-day suspension. The provider would still be able to participate in the pilot program after 90 days of assuming they completed the mandated training. Only after failing the third time will the provider be removed from the pilot program. This amendment is common sense, protects the health and well-being of our veterans, and protects taxpayers. I urge our colleagues to vote yes to this amendment. I believe this amendment would also strengthen our ability to serve our veterans with the best competency. Thank you. I yield back.
The gentlelady yields back, and I recognize myself in opposition to the amendment. The amendment is yet another requirement for community providers to take VA training. This training is already available to providers. The amendment would create more red tape and not let doctors be doctors. It does no good for veterans to have more ways to lose access to VA care. That's what the amendment does. I oppose it. Does any other member wish to comment on the amendment and the amendment?
Yes, Mr. Chairman. Mr. Chairman, the third-party administrators and the networks they've set up should be subject to at least some requirement that they meet VA's standards. It has been to my great distress that there's been an unwillingness to make that the community care networks do not provide this training. I want to yield to Representative Sherflis McCormick to respond.
Mr. Chairman, my amendment does not restrict doctors, but it actually empowers doctors by giving them adequate training so they can understand what they're recognizing. It actually strengthens and supports them in training our military personnel. What we're doing is turning a blind eye and allowing doctors who don't know what's coming at them or what to look for not to make themselves aware. A suggestion would only be a suggestion. A requirement would standardize what we're seeing in the VA and in the community, which is necessary. The VA is never going to be able to move forward, especially with community care, if we don't have some form of standardization. So this would actually promote both interests as far as the doctors and the actual patients, and we have a responsibility to make sure we're empowering them. This in no circumstance is red tape. If so, then why would doctors actually be subjected to continuing education? So this is a standard process that we already see in the VA, and it should be required to help our veterans. They have unique needs, and they deserve unique treatment. For us to deny that is a failure on our part. We have to accept what we have here, and we have a unique class of people who deserve unique treatment.
Thank you. Reclaiming my time, I recall there was a moment when we had a serious opioid safety issue with VA providers prescribing opioids and veterans paying the price as a result of it. And there was an enormous effort to get training out to VA doctors on the guidelines of VA standards on how opioids would be prescribed and how they'd be monitored. That could not be required of our community care providers. Because why? The third-party agreements wouldn't allow for that. It's common sense that when VA was trying to respond to an opioid crisis within its own midst, that it responded internally with its direct care system. But it's crazy that you want to say that my Republican colleagues on the other side want to say that community care is VA care. But if the same standards don't apply to community care, if we don't upgrade the awareness of community care doctors about how and when opioids should be prescribed and how they should be monitored, that is not really VA care. That is something else. That is a lack of attentiveness to the very specific needs that veterans need because of who veterans are, whether it's post-traumatic stress disorder. Community care providers may not have the specific background or understanding about how to respond to that, or traumatic brain injury. VA doctors, because of the academic affiliations that VA has, this is part of the culture of medicine within the direct care system. And to say that we don't want to have third-party administrators and the networks they set up have their provider networks reflect this similar expertise, this to me does not make any sense, and it is not good for the veteran. And I yield back, Mr. Chairman.
Representative Dexter, you're
Yes,
recognized.
thank you, Mr. Chairman, and I very much appreciate your point about letting doctors be doctors, and I normally do not support mandates, but in this case, this is not a mandate for all doctors, it's just a mandate for doctors who wish to treat veterans with these issues so that they can get those community care contracts, and that should be the expectation, that they have the same level of training and background to address these issues as VA physician, so the information that they receive is not mandated unless they want to receive that reimbursement for taking care of the veteran, in which case the veteran should have the same access to the same quality of care that they would expect at the VA. So I strongly support this amendment for that reason.
Appreciate that. Anybody else? So the important thing to remember here is that each one of these community care providers actually have a contract with the VA. VA can require already certain things of those, but that's the flexibility that's left to the secretary. So with that, anyone else seek recognition? Seeing none, the question now occurs on agreeing to the Shifless-McCormick amendment to the amendment in the nature of a substitute. All those in favor say aye.
Aye.
All those opposed, no. No, independent chair, the noes have it. The amendment is not agreed to. And with objection, the motion to reconsider laid
I
on.
would like to request a recorded vote.
A recorded vote has been requested. Pursuant to committee rules, this vote will be postponed. I now recognize Representative Takano to offer an amendment number 8 to amendment to the nature of substitute.
Mr. Chairman, I have an amendment to the desk, to the ANS, to HR 740 at the desk.
The clerk shall report the amendment.
Takano Amendment
I
Number
ask
8.
unanimous consent that further reading of the amendment be dispensed with without objection. So ordered. The gentleman is now recognized for 5 minutes for his amendment.
Thank you, Mr. Chairman. My amendment requires that community providers offer substance use disorder treatment to veterans under the pilot program in Section 202 be accredited by both the Commission on Accreditation of Rehabilitation Facilities and the Joint Commission. In addition, it would bar these providers from directly marketing to veterans or using patient recruiters to enroll veterans in their services or programs. I agree with my colleagues across the aisle that all veterans who are ready to seek assistance with substance use disorders should be able to quickly and easily access high-quality treatment. However, the rehab industry is rife with bad actors, and VA must have guardrails in place to ensure the quality of the care veterans receive in the community. As the Health Subcommittee discussed at a hearing on this topic early this year, VA lacks oversight over the community care providers from which veterans receive substance use disorder treatment, or many other kinds of community care. VA does not track whether veterans receiving care in the community are getting better care or more timely access to care than at VA. The level of treatment and support that veterans receive from these providers is also not tracked. If that weren't bad enough, drug and alcohol rehab facilities hold a track record of deceitful, harmful, and in some cases, deadly practices. For example, in August 2021, one such provider's lax safety standards allowed a patient to fall from a designated patient and smoking area on the roof of its facility, rendering the patient permanently paralyzed. My amendment would ensure that veterans only receive care from accredited, vetted providers that meet the quality of care standards. The accreditation process also ensures that there are mechanisms by which bad actors will face consequences for actions that harm their patients. Worse yet, VA does not have a fee schedule for residential rehabilitation treatment. This sets up a concerning incentive for bad actors to enter VA's network, effectively set their own rates to provide care to veterans and exorbitantly bill VA for reimbursement. This is unheard of in the private sector, that a provider could set their own rates and get them paid. This issue was further highlighted in December 2024 when VA's Office of Inspector General issued a fraud alert notifying veterans of reports of treatment centers targeting veterans through illegal and unethical advertising practices. These providers clearly have a vested financial interest in treating veterans. The pilot program in the chairman's ANS, which would allow veterans to access residential rehab without VA referral or authorization, would place veterans at even greater risk of being targeted by bad acting for-profit actors. for-profit motivated actors. My amendment's restrictions on advertising to and recruiting veterans would help keep veterans safe from such fraudulent practices. Part of keeping our promises to our veterans includes ensuring they can receive care quickly and easily. It also includes conducting vigilant oversight to ensure that the care they receive is safe and effective. To this end, my amendment would help VA filter out fraudulent and harmful treatment providers that take advantage of veterans in vulnerable positions and prioritize profits over quality care. With that, Mr. Chairman, I yield back.
The gentleman yields back, and I recognize myself in opposition. This amendment would add back in red tape we are trying to cut with this bill. The VA has guardrails in place with residential programs to ensure they are accredited. I'll say that again. They already do that to make sure they're accredited. Further, there are many direct market prohibitions in the VA contracts. These are matters the agency should handle through contract negotiation, not legislation. Does any other member wish to comment? Seeing none. The question occurs on agreeing to the Takano Amendment number 8 to the amendment in the nature of a substitute. All those in favor say aye.
Aye.
Opposed, no. No. In the opinion of the chair, the noes have it.
I request a recorded vote.
A recorded vote has been requested pursuant to committee rules. This vote will be postponed. I now recognize Representative Miller Meeks to offer her amendment to the amendment in the nature of a substitute.
I have an amendment at the desk.
The clerk shall report the amendment.
Miller Meeks amendment. Amendment to the
I
amendment.
ask unanimous consent that further reading of the amendment will be dispensed with and without objection so ordered. The gentlewoman is recognized for 5 minutes to explain her amendment.
Thank you, Mr. Chair. When veterans receive community care referrals, the referrals are only valid for a fixed period of time. That's because sometimes a referral is not just for one appointment, but for a health problem that may require multiple appointments. In addition, it could well be that the provider doesn't get the request for the appointment until after the appointment time has already started. The idea is that over the course of a few months, the veteran should have the opportunity to see a specialist as many times as it requires or is directed medically. As a physician, I know this problem firsthand as I was a community provider. However, due to provider shortages and bureaucratic delays, veterans may not get seen until halfway through the authorized time period or even longer. Many times the referral will expire in the middle of a treatment course, which requires the veteran to go through the process of getting a subsequent referral, which is more paperwork, more stress. Veterans don't like it, and nobody likes it. This amendment includes the text of my START Act, which would address this issue by ensuring that the validity of that referral begins only once a veteran has attended their initial appointment. This way, the veteran is able to benefit from the entire referral time period, rather than feel pressure to beat a bureaucratic clock. This amendment is an affirmation of putting the veteran first, and that the care should happen on the veteran's timeline, not on the VA's timeline. I urge my colleagues to support this common sense amendment. Thank you, Mr. Chair. I yield back my time.
The gentlelady yields back. I recognize myself in support of the amendment. My friend and colleague, Representative Miller Meeks, Dr. Miller Meeks, has discussed the current referral authorization process by the community care and is not centered on the veteran, but the VA bureaucracy process. This amendment would fix that process so that it is focused on the veteran's timeline, not on VA's. Simply speaking, the clock should only start ticking once the veteran gets care. This would not only make it easier for the veteran, but would also allow providers to focus on caring for veterans rather than chasing needless deadlines. This would be simple and efficient fix, and I urge my colleagues to support it. Support this amendment. Does any other member wish to speak on the amendment? Seeing none. The question now occurs on agreeing to Miller Meeks' amendment in the nature of a substitute. All those in favor say aye. 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 All those opposed, no. In the opinion of the chair, the ayes have it, and without objection, the motion to reconsider is laid on the table. I now recognize Representative Barrett to offer his amendment in the nature of a substitute.
Thank you, Mr. Chairman. I have an amendment at the desk.
The clerk shall report the amendment.
Barrett amendment. Amendment.
I ask unanimous consent that further reading of the amendment be dispensed with and without objection, so order. The gentleman is recognized for 5 minutes to explain the amendment.
Thank you again, Mr. Chairman, and thank you to the committee for consideration of my amendment. The amendment in the nature of a substitute would add my bill, the Veterans Hearing Health Expansion Act, to Chairman Bost legislation, the Veterans Access Act, and I appreciate your willingness to take up this amendment for consideration today. This amendment is fairly simple, and it would just make it easier for veterans to access hearing aid services in their communities and make it an easier process for them to follow. Right now, VA community care programs will reimburse providers for health care at community care providers that will reimburse right now for audiologists and other specific hearing specialists, but it does not currently include, and it actually excludes, licensed hearing aid specialists. These professionals are able to adequately fit, adjust, and repair hearing aids, but they're not allowed to help our veterans in this process. This bill and this amendment now, adding this bill, will cover that gap in coverage that often forces veterans to travel long distances or wait extended periods of time to receive care only at a VA facility, even for far simpler procedures like getting a hearing aid refitted or maintained. My bill will fix this problem by allowing veterans to seek care from licensed hearing aid specialists in their local communities, ensuring faster and more convenient access for the services that they need. Veterans deserve timely, high-quality care no matter where they live. Expanding the VA's community care program to include hearing aid specialists when it already covers other audiology professions is a common sense way to achieve that goal. This bill is a simple fix that will make a big difference, especially for veterans in rural communities, not just in my district and in my state, but across America as well, by giving them more access to options and less red tape when it comes to maintaining their hearing health. I urge my colleagues to support my amendment, and Mr. Chairman, again, I appreciate your willingness to take it up today.
Gentleman yields back. I now recognize myself in support of the amendment. The amendment would recognize hearing aid specialists in the community care network. Take it from me, when you serve in the armed forces, you tend to come across a lot of loud noises and things. The hearing damage we get while serving worsens and never gets better. I think it's important to increase access for our veterans to hearing aids and those who specialize in them. I thank Representative Barrett for this amendment, and with my voice, I support it. That's why I voiced some of my support for it. Does any other member wish to comment? Ranking member.
Mr. Chairman, thank you. I reluctantly, and I underscore reluctantly, must oppose this amendment, and I encourage my colleagues to do the same. I would have liked to have been able to work with Mr. Barrett to improve this amendment before it was offered, but unfortunately, we were not aware it would be offered until yesterday. While I'm not opposed to hearing instrument specialists being able to see veterans through VA's community care network, I'm concerned that this amendment does not set forth the same qualification standards for community providers that VA has established for the hearing aid specialists that it provides. In response to a 2016 law that required VA to begin hiring hearing aid specialists, VA established a set of qualification standards. To practice at VA, these individuals must be under the supervision and direction of a licensed audiologist, be licensed and hold active board certification from the National Board for Certification in Hearing Instrument Sciences. I am concerned that Mr. Barrett's amendment would result in veterans being referred to less qualified providers in the community than they would otherwise be seen at VA. In addition, the section of Title 38 that would be amended by this measure does not list any other specific professions or occupations that are eligible to participate in VA's community care program, and I don't think it's wise to start doing that here. Right now, the law just says health care providers are eligible to provide VA's community care network, participate in VA's community care network if they participate in Medicare or work at the Department of Defense, Indian Health Service, federally qualified health centers, or meet, quote, criteria established by the Secretary, end quote. If we start naming certain professions, we run the risk of inadvertently excluding others. For this reason, I must oppose the amendment, but I would be interested in working together with Representative Barrett on a bipartisan basis to improve this legislation so that it can be considered at a future markup. I yield back, Mr. Chairman.
Does anyone else seek recognition? Somebody need. Representative Radwagon.
Mr. Chairman, I'd like to yield to Mr. Barrett.
You're recognized.
Thank you, Mr. Chairman. Appreciate the ranking member's willingness to work on this. I would just stipulate that licensed professionals are, of course, licensed by their individual jurisdictions in which they are located. So we don't do scope of practice licensing through this body, of course. So these are required to be licensed in the jurisdiction in which they are located, which I think is the extent to which we can determine the professional qualifications of an individual. I appreciate the concern about making sure that we are handling this in the appropriate manner. And I obviously support my amendment, and I urge its adoption, but I am willing to work, of course, in a good faith effort toward resolving any further concerns you have. We'd had some challenges getting responses from some of your office in the past, and I look forward to working with you to make sure that we can sew this together in the way that makes you comfortable. So appreciate it. Thank you.
I appreciate that offer. Thank you.
Any others? Seeing none, the question occurs on agreeing to the Barrett amendment to the amendment in the nature of a substitute. All those in favor say aye. Aye. All opposed say no.
No.
In the opinion of the chair, the ayes have it. Without objection, the motion to reconsider is laid on the table. I now recognize Representative Dr. Conaway to offer an amendment number 1 to an amendment in the nature of the substitute.
Yes, Mr. Chairman, I have amendment to the amendment in the nature of a substitute at the desk.
The clerk shall report the amendment.
Conaway Amendment Number 1, amendment to the amendment.
I ask unanimous consent that further reading of the amendment is dispensed with without objection. So ordered, the gentleman is recognized for 5 minutes to explain his amendment.
Thank you, Mr. Chairman. My amendment would require community care providers to receive necessary training at the VA. If a community care provider fails to comply with the required training and deadlines, that provider would be temporarily suspended from treating veterans. Time after time, we have heard from veterans that community care providers have missed symptoms or struggled to connect a symptom to a veteran's time and services due to lack of familiarity with the veteran or military, active duty, retired demographic. It's not a surprise that medical staff who do not exclusively serve veterans or those who have not served in the armed forces may face challenges in understanding the physical, mental, and emotional stresses that come with military service. As members of this committee, it is our responsibility to ensure that any physician, nursing assistant, or other direct care medical staff that comes in contact with a veteran has foundational knowledge that is necessary to detect and connect symptoms to service and provide appropriate treatment. By requiring community care providers to undergo training, we're giving them the crucial insight that they need to deliver the best possible care to veterans. I would note that this amendment holds community care providers to the same standard as VA health care or direct care service providers. If you're serving the VA, you have to undergo training that is specific and tailored to meet the needs of the veteran. We should require community providers to do the same, to undergo the same training so that they can provide exceptional care to our veterans. This training would be would be free. It could be done remotely, and would last just an hour. Of course, it's noted that perhaps the Secretary might provide additional training beyond this, but we want to make sure that there's parity between those healthcare providers who work and serve in the VA, that there's parity between those providers and the community providers that may and will continue to care for our veterans. I hope all my colleagues will join me in supporting this much-needed amendment, and I yield back.
The gentleman yields back, and I recognize myself in opposition to the amendment. Every minute of red tape providers have to comb through takes away from the patient care. This amendment from the other side of the aisle would force providers to put time into special training courses instead of veterans. We should make it easier, not harder, for doctors to see veterans. If a veteran wants community care, the veteran should get it. If a veteran wants direct VA care, the veteran should get it. Many providers already do right by veterans because they do right by their patients. We should let doctors be doctors. I oppose this amendment. Does any other member wish to speak on the amendment? Seeing none. The question occurs on agreeing to the Conaway Amendment Number 1 to the amendment on the nature of a substitute. All those in favor say aye. Those opposed, no. No. In the opinion of the chair, the noes have it. Without objection, the motion to reconsider is laid on the table. A recorded vote has been requested pursuant to committee rules. This vote will be postponed. I now recognize Representative Morrison to offer an amendment to the amendment in the nature of a substitute.
Thank you, Mr. Chairman. I have an amendment to the amendment in the nature of a substitute to H.R. 740 at the desk.
The clerk shall report the amendment.
Morrison, Amendment Number 2.
I ask unanimous consent further reading of the amendment be dispensed with, and without objection, the gentlelady is recognized for 5 minutes to explain her amendment.
Thank you, Mr. Chairman. My amendment would require VA to update its public directory of community providers to include information on which providers have taken VHA's 1-hour introductory training course on veteran care. My amendment would also push providers who have taken this training to the top of the search results. VHA offers a course for community providers to improve their competency in treating conditions that disproportionately affect veterans, including mental health conditions, TBI, PTSD, and military sexual trauma. This training also provides an introduction to military culture so providers can learn about how identification with military culture can play a role in patients' perception of injury and illness and can influence the response to treatment. By incentivizing community providers to complete this training course, which can be done in just an hour, we can help ensure that our veterans always get the high-quality care they deserve, whether at VA or in the community. As more veterans receive care in the community, we should make sure that the veteran has all the necessary information to make an informed decision about which community provider is best suited to treat them and understand their unique needs. I urge my colleagues to vote yes on the amendment, and with that, I yield back. Thank you, Mr. Chairman.
The gentlelady yields back. I recognize myself in opposition to the amendment. The amendment would create more burdens for community providers. It is my understanding the VA may already be looking to do some of this in the next round of contracts for the community care, but I leave it up to the negotiations between the VA and the contractors that they award. This amendment does not belong in legislation, and I oppose it. Does any other member wish to comment? Seeing none. The question occurs on agreeing to the Morrison amendment and amendment in the nature of a substitute. All those in favor say aye. Aye.
Aye.
Those opposed, no. No. In the opinion of the chair, the noes have it.
Mr. Chair, I ask for a recorded
A
vote.
recorded vote has been requested pursuant to rules. This vote will be postponed. I now recognize Representative Conaway Dr. Conaway to offer an amendment to number 9 to the amendment in the nature of a substitute. The clerk shall report the amendment.
Conaway Amendment Number
I ask
9.
unanimous consent the further reading of the amendment is dispensed with without objection. So ordered. The gentleman is recognized for 5 minutes to explain his amendment.
Thank you, Mr. Chairman. My amendment adds a new section to the ANS which would require the VA to establish a fee schedule for community providers of residential substance use disorder treatment. Under the Mission Act, the VA typically pays Medicare rates for community care. However, Medicare does not cover residential substance use disorder treatment. And in more than 7 years since the enactment of the Mission Act, the VA has never established its own fee schedule for this service. Instead, the VA has been reimbursing community providers of residential rehabilitation as a percentage of billed rates. In some cases, the VA has been paying these providers $6,000 a day. For the 20,000 veterans who receive residential rehab in the community between fiscal years 2021 and 23, the VA paid an average of $69,000 per referral. Because of this, many community providers engage in predatory marketing practices targeting veterans. When they see veterans, they see dollar signs. Late last year, the VA's Office of Inspector General issued a fraud alert warning veterans and the public that certain drug and alcohol rehabilitation facilities are attempting to exploit veterans for profit. In May this year, the Department of Justice announced that it had secured a civil settlement of $19.75 million from Seabrook House, a New Jersey drug and alcohol rehabilitation center. The settlement resolved allegations of submitting false claims for payment to the VA's community care program and New Jersey's Medicaid program in connection with drug and alcohol abuse treatment. VA's Office of Inspector General is continuing to investigate similar allegations against other rehab providers elsewhere in the country. In addition to creating an incentive for community providers to exploit veterans for profit, not having a fee schedule for residential rehab places the VA at risk of significantly overpaying for these services. That is wasteful and is simply not sustainable for the VA to continue paying for these services at these astronomically high rates. The VA is currently paying far more than Medicaid or any commercial insurer pays, and community providers are capitalizing on it. VA officials have assured the committee staff that they have been working to establish a fee schedule, but the department has yet to do so. My amendment would require the VA to establish a fee schedule for residential substance use disorder treatment within 180 days of enactment. I urge my colleagues to support this amendment, and I yield back.
The gentleman yields back, and I recognize myself in opposition to the amendment. The amendment is unnecessary as a fee schedule for VA's community care providers is already published annually on their community care website. My staff would be happy to connect with your staff and after markup to show you where you can find it. Does any other member wish to comment?
Yes, Mr. Chairman.
Ranking member.
Mr. Chairman, there may be some misunderstanding about what the community care fee schedules do in fact publish. They establish fee schedules for other types of care, but for residential substance abuse treatment, they have not published those fee schedules. I would ask that we be made privy to this if this is true, but this is an extraordinary problem that the providers of substance abuse treatment set their own fees and can bill VA and get paid for it. This is an incredible situation, and it opens up the veteran to being targeted for all sorts of abuse. There is a fee for dental, for example. There's a fee schedule for dentists, but not for residential rehabilitation for substance abuse. And I would think any provider in America, any common sense citizen who's dealt with any pre-negotiated fees for how much their health plan will pay for something would be surprised to find out that VA does not have a set fee schedule for the providers of residential substance abuse treatment.
So, you yield back.
I would just say, Mr. Chairman, I think this amendment is a very common sense amendment, and most Americans would say this is crazy to allow providers to bill VA for whatever they want and get paid for it.
Thank you for your comments. Anybody else? Okay. That being said, no one seeking recognition. The question occurs on agreeing to the Conaway amendment to the amendment in the nature of substitute. All those in favor say aye.
Aye.
All those opposed, no. No. In the opinion of the chair, the noes have it, and the amendment is not agreed to. With it, according a record code vote having been requested pursuant to committee rules, the vote will be postponed. Because votes are pending on this bill, we will move to consider of the next bill on the agenda.